All right. Well, anyway, I want to now introduce Dr. Dara Eisner. And Dr. Eisner is a pathologist and leads the molecular pathology lab here at the University of Colorado. She was previously at the University of Pennsylvania, where she developed a wonderful reputation and has continued that trajectory here. The University of Colorado, it's really not an accident at all that that we're here, and that is because of folks like Ross and others that have made this a premier center for lung cancer in general and targeted therapies particularly. And the molecular pathology work that Dara and others have done has really been a pace setter. What I would say also makes Dara essentially unique is she is a very compelling, engaging speaker on something that isn't always intuitively compelling and engaging. And so I think it's really very valuable to have somebody who's a gifted communicator talking with patients as well as other doctors. And so thank you very much for talking to us about the world of targeted therapy and molecular testing.
Can I get unmuted? Unmuted. Yeah, well, I try to stand in front because my general experience is that podiums come up to my eyeballs. Looks like I turned it off in my pocket. Okay, I'm gonna stand out here. I did my best to try to make this a little bit on the basic side. I wanna try to run through some of the basics of molecular testing for you guys. And, okay, I gotta do something else. Okay, so I really set this up without putting a whole hour's worth of content into it because I want to try to make it interactive. Please stop, ask questions. If you would like me to go back over something or explain something in more detail. I also have a whole bunch of slides that I put at the back of the talk to be able to answer questions about things that I didn't put in here but that I anticipated might get asked. So just feel free to stop and we can talk about things. And I tried to make it basic. You'll see that I do have some technical language in here, which I've tried to explain the best I can. So Ross and I like to talk about things like EGFR, ALK, and ROS1 as ripped genes. I've given a couple talks called ripped genes. What do I mean when I talk about ripped genes? Not these. That's actually Ross's knee. This is what I'm talking about with ripped genes. So this is a little icon I made a little while ago because we like to think about these things as genes that can fight back. And when we think about lung cancer and the genetics underlying lung cancer and how we tease it apart, we often talk about it in terms of these pie charts. And we all love these pie charts. They're a little difficult to get published, surprisingly enough, but we love these pie charts because it's a nice visual way to think about how we divide cancer into these pieces of pie, right? So we talk about KRAS being this piece of pie. So far, we still haven't quite figured out what to do with this KRAS slice of the pie. But we have these other slices of pie that we increasingly know what to do with them. And what we find is that as we do more and more testing, we discover more and more slices. Unfortunately, the slices keep getting smaller as we try to divide this up. But we like to think about this way. And this also helps us think about how to proceed with testing, because we want to make sure that any testing we do allows us to get all of these slices. So I thought I would just start off with some molecular testing basics, because this is stuff that people know that their tumor got sampled and they got a report back and it has something that's in there, but how did you go from A to the B here? So there are some very traditional methodologies to detect mutations. One is called sequencing, and I've tried as best as I can to put in brackets the technical term for things. So you can stop me if you want to keep talking about that. So we have this thing called sequencing. That's kind of the oldest fashioned thing we have, and it dates back a ways. And it's really the first thing that was used to apply in the clinic, where we could take this older technology and apply it. And it has advantages, it has disadvantages, and I'll try to go through a couple of those. And then there's the next sort of step of that is this targeted mutation testing. And I've given you one example of that, which is this mouthful allele-specific real-time PCR. There's no test on this at the end, but that is a mouthful. And so these are just examples of some of the technical language that really summarize two basic concepts, which is going back to something that was discovered over 50 years ago in terms of how to sequence pieces of DNA, which has now been applied clinically to cancer samples, to more advanced technology that lets you say, does this sample have the EGFR L858R mutation, right? You're asking one very, very specific question with a test that asks, does this cancer have the EGFR L858R mutation? Now, traditional methodology for detecting fusions or rearrangements is FISH, which stands for fluorescence in situ hybridization. That is also a mouthful. What does that mean? Fluorescence, well, that means that we have to put fluorescent tags on things and look at them under a fluorescent microscope. So this is about a technological piece. It requires a dark room and a specific microscope with specific filters. We don't have to get into the details. The in situ part means that we're actually looking at it on cells. So we're looking at it cell by cell. That's the in situ part. Hybridization is the part where we take a piece of DNA and we get it to stick to the DNA in the cancer cells. That's hybridizing. So that's what this term really breaks out to mean, and I'll show you a little bit of that. Now, when I say non-traditional, I'm putting this in quotes because the further along we go, the less and less non-traditional next-generation sequencing becomes. But historically, we think about next-generation sequencing as a non-traditional methodology, and you can theoretically use it for both. You can use it to detect mutations and fusions and even other alterations. So the thing that I want to impart upon you more than anything else is that among all of the technologies I'm going to talk about today, among any of the technologies you might read about, anything you might see in a report, there is no such thing as a perfect test. Every test has a limitation. Every test has a possibility of a false positive or a false negative. The goal of a laboratorian, the job of a laboratorian like me, is to minimize the probability of a false positive and false negative, and to understand best when a false positive or false negative is more likely. But there is no such thing as a perfect test. So you have to recognize that from the outset, that no matter what testing you get, there's always the possibility of a caveat being attached to that test. Okay, so let's talk a little bit about some of the actual tests. FISH testing I thought I would focus on because I know that there are a lot of people here who are particularly interested in ALK and ROS1 rearrangements. FISH testing is something where we typically look for a gene location, also called a genomic locus, to separate in space. And this comes back to the in situ part. So what you see here are these blue blobs. Those blue blobs are actually nuclei of individual cancer cells. That's the in situ part. You've got some green dots and some red dots. That's the hybridization part, where that piece of DNA that's labeled either green or red has been stuck to the DNA that matches it inside the cells. Now what we've just shown here schematically is the ALK locus. And for ALK rearranged lung cancer, what happens is this location gets split into two and a new gene goes in there. And I know you guys have heard a lot about this in other formats earlier today. But the way we detect this is because this thing got split apart, we actually look for that red signal and green signal to separate in space. So here, for example, where these yellow arrows are, you can see, well, I don't know how well it's projecting, but there's some spots in here where the red and the green are right next to each other. They're married, they're fused right on top of each other. And if they're married well enough, sometimes that green and red create interference with each other to look yellow. That is an intact locus. Here, I'm not sure how well it's projecting, there's a red and a green that have been separated. That's what we're looking for to be able to diagnose an ALK rearrangement using this technology. We do the same thing for ROS1. Now, one of the caveats about doing ALK testing is that we have to cut the cells into pieces in order to do it. We have to lay them down on a slide, which means we have to slice those tumor cells. And when you slice tumor cells, you get this thing called truncation artifact. So if you can imagine that slicing through a cell can give you a section that looks like this, where the red and the green stay intact. So this is what the slice looks, and this is what it looks like when we look at it from the top, where you're looking at those blue blobs. That red and green are right next to each other. If the slice happens to catch where's my light here? I lost it. If the slice happens to catch right between that red and green, which it does sometimes, your cell will look like it only has a red, when in fact that's just an artifact of how that cell got sliced. So this can look like a positive signal, when in fact it's just how the cell got sliced. So this is part of the test. If you have looked at an ALK rearrangement report and it says this is positive because greater than 15% of the cells had this positive signal, that 15% is how we account for the fact that some of this slicing can happen sometimes in a way that creates a sense that is positive when it's not. So that's how we threshold these tests. When we do these tests, each one of those blue blobs is looked at separately. So a technologist sits and looks at every blue blob and counts a certain number of blue blobs, a certain number of nuclei. They count them up and they count. In this cell, I had a red and green signal next to each other. In this next cell, I had a red and green cell next to each other. Oh, look at that. In this cell, I had a red signal and a green signal, and they were separated. And that is how we are able to look at it. And even though each cell is counted individually, we count all of the cells up as an aggregate to come up with an answer at the end. Now, when we talk about mutation testing, there are a couple of different considerations. So I showed you the main considerations for FISH testing, which is that we slice these cells up, so you have to think about how signals can look in sliced up cells. For mutation testing, it's a little bit of a different mix. We talk about things called clinical and analytical sensitivity. So clinical sensitivity is what does the test look for? Not all tests detect every possible alteration. That comes back to the thing I was telling you about before. If I design a test that says, does this sample have EGFR L858R in it? I've designed a test to look at one very specific thing. It asks one question, right? So clinical sensitivity describes a parameter of the test that tells you what questions are being asked. Analytical sensitivity is how sensitively does the test look for these changes. That's a really important question when it comes to tumor populations. So all tumor populations, every biopsy, every resection is actually a mix of tumor cells and non-tumor cells. And this piece called analytic sensitivity is about how to find the signal from the tumor cells in the mix of the non-tumor cells that those tumor cells come out in. So some tests require a much higher proportion of tumor cells to work, right? So a test that requires that you have 30% tumor cells in the population is a different test than a test that requires only 5% of tumor cells in the population. So these are characteristics that are inherent to the test. Now, I am not going to read this mess, okay? And you guys will get my slides emailed after the fact. I apologize that I didn't get them in advance. But we've got this thing called clinical sensitivity. We've got this thing called analytic sensitivity. The reason I've got them here on a seesaw is because they tend to be inversely related. A cell that works on a very low proportion of tumor cells tends to ask only a couple of questions. A test that tends to ask a lot of questions tends to need a lot of tumor cells. So this is my in English version of that big mess. It's about needles in haystacks. So a test with really excellent analytic sensitivity can detect one needle in a haystack, but it can only detect one flavor of needle, we'll say a purple needle, right? A test with really excellent clinical sensitivity can detect a purple needle and a red needle and a green needle and a white needle, but you need more of them in order for it to work. And as I said, these things tend to be inversely related. So I have a test that says, does this patient sample have an EGFR L858R mutation? I'm asking one very specific question. I can get that down to one needle in a haystack. I can get that down to one needle in a giant haystack, right? If I want to ask 15 questions at the same time, I need a smaller haystack and more needles. We're good? Questions? Okay. All right, so now let's move on a little bit from the technology, and we'll come back to some of the pieces of the technology as we interweave it into some of these other questions. Who? Molecular testing in lung cancer. Who should get tested? All patients with advanced staged adenocarcinoma should get tested. There is just no question about that. That's in all the guidelines at this point. And from the perspective of people who are helping other people navigate their cancer diagnoses, navigate this process, it's very important to make this message very clear. A patient with advanced staged adenocarcinoma must get tested. It gets a little more confusing though, right? If everything were that easy, we'd have a much easier time getting the message out. Now we start to get into some of the complexities and the subtleties. So a patient with advanced stage squamous cell carcinoma in whom you cannot exclude adenocarcinoma. So among the people in this audience, how many people either are a patient of, know of someone, or are caring for someone whose lung cancer was diagnosed through a teeny tiny little biopsy? A lot of people, right? Most people who wind up with a diagnosis and wind up treated for lung cancer, that diagnosis came from a teeny tiny little biopsy. So why do we deal with this way for squamous cell carcinoma? It's because of this entity called adenosquamous carcinoma. And adenosquamous carcinoma, statistically, is just as likely to have an EGFR, ALK, or ROS1 rearrangement as adenocarcinoma. But if you put a little teeny tiny needle in there and only hit the squamous part, you wouldn't know that there's adeno hiding in there. So if somebody has a biopsy, and that biopsy says squamous cell carcinoma, but it only came out with this teeny tiny sampling, that patient should also be a candidate for molecular testing. Other lung cancer types, large cell carcinoma, sarcomatoid carcinoma. When we think about lung cancer, we tend to lump it into two big categories, small cell and non-small cell. But within non-small cell, there's all of these other categories. And although I've just talked about the two big ones, adeno and squamous, there are a bunch of other less common ones. And these days, we tend to think those less common ones also deserve to be molecularly tested. Now, this concept that we talk about, pure squamous cell carcinoma, this is a difficult topic. This is a difficult area, because what defines pure squamous cell carcinoma? Well, you can't really define something as a pure squamous cell carcinoma off of a biopsy. But if somebody had a resection and it looks like squamous cell carcinoma all the way through, it doesn't look like there's any adenocarcinoma in it, we tend to think those tumors are much less likely to have an alteration that we know what to do with right now, much less likely to have an EGFR alteration, ALK rearrangement, or ROS1 rearrangement. Not impossible, just vastly less likely. So we tend to think about the relative value of doing testing. We start to bring that back to our clinical parameters. So somebody who has a resected squamous cell carcinoma that's a pure squamous cell carcinoma, if they have a low or no smoking history, that sort of starts to raise the probability that one of those targetable alterations might be there. Now, when should patients be tested? Well, I just told you that everybody with advanced stage adenocarcinoma should be tested. Well, implicit in that is they should be tested as soon as possible, right? If you have a diagnosis of advanced stage adenocarcinoma, that testing should be initiated right away. Now, the problem here is a communication barrier, right? So let me just walk you through a little bit of the process. Somebody goes to their primary doctor, chest x-ray, has a cough, gets treated for pneumonia. I'm sure this sounds familiar to somebody, right? Pneumonia doesn't get resolved. They go get an x-ray. Oh, it looks like there's a nodule there. Now I'm going to send you for a biopsy. The biopsy comes back with cancer in it. Well, at the point in time that the biopsy was sent to the pathologist doesn't know if the patient is going to go get surgery. The pathologist doesn't know if the patient has advanced stage. So it's very hard to set up rules that says every time a cancer comes in, it should be sent. I will tell you, as a molecular pathologist, as somebody who does the part where we do the testing, if I get a teeny tiny little biopsy to do testing on, and then I look up in the patient's record that they're scheduled for surgery in a week, I'm not going to test on that teeny tiny little biopsy, right? I'd much rather test on the larger specimen. So it's not a good use of the specimen, it's not a good use of time, it's not a good use of resources to do the testing if someone's about to have a surgery. So there's a communication issue in terms of knowing how to get the right piece of tissue tested at the right time. And so this requires that facilities set up these very tight communication strings. If this is adenocarcinoma, please have it tested. Those are things that facilities all around the country are working on. They're working on tightening and improving. Okay, so one of the quintessential questions, should patients with early stage disease be tested at the time of diagnosis surgery? All right, let's just do a quick informal poll. How many people think that if somebody just got a diagnosis of earlier stage lung cancer, they should be tested right away? How many people think, no, they should wait? Okay. I actually am more of a believer of no, they should wait. So let's talk about why. So there's pros and cons to testing at the time of diagnosis or surgery. Pro, test results are immediately if the patient happens to recur, right? That's a big bonus, right? The presence of a targetable alteration may signal suitability for an interventional trial, an adjuvant or neoadjuvant trial. That's potentially therapeutically beneficial. And importantly, there's patient knowledge. But what are the cons here? The cons here are, first of all, the testing may be unnecessary. We know that some people, particularly those with the earliest stage, do not recur. So there is some degree to which that would be unnecessary testing. I think the most compelling argument is if it takes some time between the time of diagnosis and the time of recurrence, our testing is moving so rapidly, our advances in testing are so extraordinary that that interval of time could actually represent a substantial change in how testing is done. It could represent new targets that weren't represented on earlier testing. There's a question that always comes up about insurance coverage. I've never seen an issue on this side of it. We don't really see that issue. I could get into the mechanics of why, but the quick version is that the code that is used for lung cancer doesn't distinguish between early stage and late stage. Now, patient knowledge is a wonderful thing, but there are some people who do better not knowing, right? So if you have a disease and you get a test that says this is associated with a less favorable prognosis, that doesn't do great things for your psyche, right? So there's two sides to the coin of knowledge. Reflex testing is something that institutions are struggling with. Yeah.
I just wanted to raise one more issue on that. I think it's saying the two sides of the coin for knowledge is this concept of a curse of knowledge. And you don't have on the table, and you can't unknow what you know. And that it's not rare that people with an early stage 1 or 2 cancer are found to have a mutation. And even if no systemic therapy is of proven value or indicated, it leads to this gnawing, boring question of should you be on oral therapy for this? And if so, do you do that forever for something that may be cured without any proven knowledge?
I agree completely. So just to recapitulate what Jack just said for online, there's the component from the previous slide where it's not just about anxiety, but it's also about you can't unknow what you know. And, you know, if a patient is determined to have an alteration that is potentially targetable in early stage, does that suddenly give somebody some sense that they should be on that drug now? Give me that drug this second, even though there's no data to say that it would benefit me? So I agree completely that sometimes, and to some degree, this is individual person specific. Only you know how your psyche works, right? So to some degree, it's individual patient specific of knowing how you might cope with information that may or may not be useful today. Oh. I agree. There are pros and cons, and you know, every institution takes its own approach. So I'll recapitulate the question a little bit, which is that if a patient has early stage disease and then a number of years later recurs, if their tumor was tested at the time of diagnosis and then is tested again at the time of recurrence, that you might be able to identify differences between those tumors, which could be useful. And I also agree with that. And so the reality is that there's no right answer. And so from the academic learning perspective, I think there's value to doing it. So it depends on what the values and the priorities are to a large degree. So institutions really are struggling with the implementation of reflex testing. There are logistical issues. So those are usually dovetailed very tightly with the communication issues. So as I just described to you, a small biopsy that shows lung adenocarcinoma, well, the person who actually did the biopsy, the interventional radiologist who did the biopsy, doesn't know whether the patient should get molecular testing. The person who received the sample, the pathologist, doesn't know whether the patient should get molecular testing. So communication strings are a critical part of that. The logistical issues are a critical part of this, and this has been addressed to some degree in guidelines. How long should it take from the time a diagnosis is made until the tissue is sent to a molecular lab for analysis? So logistical issues are attached to that. And unfortunately, in this world of medical care in the US, there are billing issues. So something that people generally are not aware of is that for some insurance providers, mostly Medicare, but also some other providers, if a hospital has a biopsy and they send it for molecular testing within a certain window of time, that facility actually gets billed for the biopsy, not the insurance company. So there's almost a disincentive to send things quickly. Okay, so let's talk about how. How is the big question, right? So as we talked about before, you've got a growing list of targets. As the list of targets gets bigger and bigger, the pieces of pie get smaller and smaller. So you have to be able to think about the how in terms of that pie, right? So you need to balance all of these different things. You need to balance how you can identify the relevant alterations, including those smallest pieces of pie. You need to balance turnaround time. This is critical, right? I hear stories all the time. This happens all the time in my lab. We've got a patient coming in a week and a half. Can you please get us the answers back? Because otherwise I have to start them on chemo, right? That turnaround time becomes critical. Somebody with lung cancer does not want to be told to wait another week to see if maybe they have this targetable alteration. There is the pressure to get therapy started. So this turnaround time, which you will see that I've abbreviated in later slides as TAT, is a really critical part of our thinking when we think about testing. The use of tissue. Now, somebody who's had a surgical resection is less of an issue. But for those of you who know that the tissue that was taken is this teeny tiny biopsy, we have to be very, very careful with how we use that. Because if I use up all of that tissue and I don't get all of the possible answers, then we're stuck with either not having the answers or having to start the process over of a new biopsy, a new delay, right? So we're very mindful about the use of tissue. And again, I hate to bring it up, but it's the reality of the world. Cost and reimbursement and funding is a critical part of how we have to think about this. Because a laboratory that does this testing, if they lose money every time they do the testing, they will shut the testing down, right? So we have to build an environment that's conducive to facilitating the testing. Okay, so when we talk about testing approaches, I want to show you some different schematics of how different organizations, different institutions think about how to approach the testing. There's the one-at-a-time sequential testing approach. I would say this isn't used as much anymore, but it does happen. And I just built one algorithm. It's not the algorithm, but this is just to show you an example. So for example, somebody has a sample submitted, and first they send it for KRAS mutation. Yeah, it's true, KRAS mutation doesn't have a specific therapy associated with it, but since this is the biggest slice of the pie, that's the easiest one for us to do first. So we'll do that one. And if it's positive, you stop. And if it's negative, then you go on and you do an EGFR mutation. And if it's positive, you stop. But if it's negative, you go ahead and you do an ALK rearrangement. So you do each of these sequentially until you find something or until you've run out of options. So that's one approach. Another approach is one-at-a-time tests, but doing them in parallel. So at the same time, you run a KRAS mutation, an EGFR mutation, and ALK and ROS1 rearrangements, potentially by FISH. And if it's positive, you use the data. If it's negative, then you think about doing some additional targets, maybe. The reason I say maybe is because in the general community, I would say in general community practice, the things I see the most are these two things having been done, usually in parallel, but not necessarily much more. Ross, would you agree? Craig, would you agree? Srish? Yeah, so, I mean, I only see sort of the back end of what happens after the fact. These guys see what happens when people walk in the door, and they agree that in the general community, there's been pretty good adoption of EGFR and ALK as a core set of testing, but not necessarily more than that. Okay, so another approach, parallel next-generation sequencing testing and fusion testing by FISH. So the idea here is that you use one test instead of an individual KRAS and EGFR and BRAF and HER2 test. You use one test by next-generation sequencing that covers these things at a minimum, and then you run these things for rearrangement separately. If positive, you use the data, and if negative, maybe you keep going, maybe you don't. And then the last option here is NGS-based testing, where you have one test that covers everything at once. Okay, so let's talk about the pros and cons of these. So you might think that the answer is obvious. You might go, oh, well, this is silly. You just do this. There's no question. You just jump right to this thing. Where's my, it's getting less strong over there. Okay, you might think, oh, this is silly. This is not up for debate. You just go right to next generation sequencing. Why are we talking about this? Well, I'll just start down here. It has the longest turnaround time Now, labs are working on how to make this shorter, right? We're all working on that. I want nothing more than to get as many answers as possible, as quickly as possible. But the reality is that if you want to bite off this big bite, it takes the longest. I say possibly the most comprehensive because NGS, I want to make very clear, NGS is a platform. NGS is not a test. So how that NGS is used is variable from testing lab to testing lab. So that's why I say it's possibly the most comprehensive, because it depends on what actually went into that test at an individual site. Now, if we go up here to the one-at-a-time sequential testing, this also has a very long turnaround time, potentially, right? So if you have to work your way all the way down to the bottom of that thread before you have an answer, that's a very long turnaround time. But if a patient is KRAS positive, that answer comes back very quickly. So it's potentially the longest turnaround time, but it's variable. It's the most cost efficient, but it's also one of the worst ways to use up tissue quickly. One of the other things about this approach is that you don't detect what we call co-mutations. Now, we tend to think that ALK and EGFR don't live together. We tend to think that EGFR and ROS1 don't live together. We tend to think that KRAS and ALK don't live together. And generally that is true, right? With reasonably high confidence, that's true. But cancer doesn't like to read what we tell it to do, right? We try to put these things down in books and define these rules about how cancer behaves, and cancer goes, screw you, right? So cancer does not read the rules, and co-mutations do occur rarely. So if you're testing one at a time and you stop as soon as you get a positive, you will never find those co-mutations. One-at-a-time testing in parallel actually has the best turnaround time. If I just do a quick EGFR and a quick KRAS and these things really fast as one-at-a-time tests, that's actually how I can get my answers out the fastest. But again, these are tissue utilization is a problem. Running NGS and FISH sequential versus in parallel, those are going to have about the same tissue utilization, but you get better turnaround time with NGS and FISH in parallel. So if turnaround time is your number one concern, this is what you do. If comprehensiveness is your number one concern, you do this. The message I'm trying to convey is that there's no one answer for everybody, right? So we get orders in our lab where we know the patient wants to make a therapeutic decision in the next week. Our oncologist wants to make a therapeutic decision in the next week. We're not going to try to get that next generation sequencing done, because Murphy's Law is, I got a sample in my lab and somebody's really needing to find it in less than a week. That's going to be the run that I need to repeat, right? Guaranteed. So we keep these one-at-a-time tests available, so that way, if the decision is ALK, ROS1, EGFR, we can get those done really fast when needed, right? Now, the approach is different from the platform. The approach is how you arrange what testing you do when. The platform is how you go about the testing. So let's talk about the pros and cons of the platform. One-at-a-time mutation test. This is the thing that I was referring to early on. It actually is a whole different type of it's many different platforms, so I'm overgeneralizing here a little bit. But one of the potential cons is limited clinical sensitivity. Back to this issue of you don't get answers to questions you don't ask. So often those targeted tests give you only one very fast answer. FISH for rearrangements. The pros to this is that it's very well established. It's the gold standard. It's relatively fast. It also has limited clinical sensitivity and can have false positives and false negatives. Now, next generation sequencing for mutations and rearrangements is, again, potentially the most comprehensive. I think one of its main issues right now is that there is the potential for false negatives, and the biggest hole in these types of tests is rearrangements, because it's just technically very challenging. And the technology is improving, it's getting better all the time, but that is one of the biggest holes. Okay, so now, of course, people want to know all about liquid biopsy. That's what everybody wants to talk to me about. What do you think about liquid biopsy, right? So let's talk about liquid biopsy. Liquid biopsy is a fancy name for a blood test, okay? So let's get that out of the way. There's nothing about it that's any different from the fact that you need to have a tube put in your arm and a needle put in your arm and get some blood out. Now, the premise of a liquid biopsy is that you're using material shed from the tumor into the bloodstream as a marker of the tumor. So this can be circulating cell-free DNA, it can be circulating tumor cells, or it can be exosomes. Now, the thing I would tell you is that this is very, very new technology. And it's very promising, but very new technology. And the thing about new technology is that very few standards are usually around when technology is very new. And in the case of this type of testing, I would argue that there are no standards. So when you're dealing with a technology in which there are no standards, it's hard to know how to compare things. It's hard to know when things are right and when things are wrong if there's not a lot of standards. So it makes it difficult to identify that needle in a haystack. Now, it so happens that with liquid biopsy, the haystack looks a little bit different than the haystack from a tumor. But you still have a haystack, and you're still trying to find a needle in it. Do you want me to stop and answer this now, or wait? Okay. All right, so liquid biopsy. A positive finding in a liquid biopsy is highly likely to be useful. I will warn you, though, that there are reports of false positives. And that's because these tests are designed to look for the teeniest, tiniest needle in the biggest possible haystack, right? And so when you design a test to be that sensitive, sometimes it picks up a false signal. Negative findings are really challenging to interpret in this setting, right? How many of you guys have ever heard of the term negative predictive value? Negative predictive value. That means how much can you believe a negative when that's the result you have? I would argue to you that the negative predictive value of these tests is very, very compromised, right? So if you get a negative result from one of these tests, is it a false negative? Is it because the tumor isn't spitting out that much stuff? Is it because the tumor's too small to have reached where it should be? There's lots of reasons these things can be negative that don't reflect the biology of what's going on. So when to use a liquid biopsy? In lieu of a biopsy, I would argue no. It's not recommended if a tissue biopsy is feasible. In parallel with a biopsy, okay, I don't see any harm to doing that except the harm to the wallet, but I don't see that it's a good substitute. For evaluation in the setting of acquired resistance, this is an interesting area. So liquid biopsy, I would say, is highly useful if it gives you a positive answer in the setting of resistance. But in the absence of a positive answer, in the absence of a defined alteration that explains resistance, I would argue this doesn't tell you that much. Now, when you talk about needles in haystacks, in the setting of resistance, your haystack isn't big, it isn't large, it's ginormous, right? So your haystack in the setting of resistance is that you have to deal with all of the noise from everything else, and you're looking for the less common event. And so because that haystack is so big, the lack of a positive finding in this setting is very difficult to interpret. And there's growing discussion about using these things as monitoring. Now, let's talk about when not to use liquid biopsy. For anybody who has had to do INRs for blood thinners, this is not an INR. This is not glucose monitoring for diabetes. This is not something you do once a week to go, oh, look at that, my numbers shifted a little bit. That's a great way to make people crazy. So this is not a regular monitoring test for a weekly thing. If you do this sort of testing right after surgery, it's not going to work very well because it's that big bolus of tumor cells that was just taken out that's actually spitting everything out into the bloodstream. Again, I would argue to you that this is not a good substitute for tissue biopsy in the setting of a first molecular diagnosis. Now, if a patient has no accessible lesion, which doesn't happen, or if a patient isn't fit for a biopsy, it's a different discussion. And then the last thing is when you have a lesion and you're not sure what it is. So particularly in the setting of somebody whose disease is well controlled and there's a new lesion that's coming up, maybe it's recurrence or progression or metastasis, and maybe it's nothing, right? And the only way to really know that is to biopsy it to see if it's tumor or something else. So I just want to draw attention to the fact that the Lung Cancer Mutation Consortium is one of many, many multi-institutional trials that deals with this. It's really through multi-institutional trials that we've been able to tackle these types of questions. When you're dealing with smaller and smaller pieces of the pie, you got to put the heads together at lots of institutions to get enough people to be able to draw conclusions. When you see these studies that have 15 ROS1 patients being studied, those aren't all at one place, right? These people live all over the country, and so it's really through multi-institutional trials that we're able to do these things, and those are supported in part by the NCI, supported in part by private companies, And it's very important that as a community, we continue to support multi-institutional trials. So let's talk about some questions. I've got one here. It says, despite what I and guidelines mandate, Medicare rules decree a 14-day wait after hospital discharge for pathology to perform molecular diagnostic testing. Do you wait 14 days? How do you overcome? Okay, so I don't want to get too into the weeds of Medicare rules, but the Medicare rules don't actually decree that you have to wait. What it decrees is that if you do the testing inside of that window, that you can't bill Medicare separately for it. So this is part of the fact that when somebody goes to the hospital for a procedure or a surgery, the hospital gets one lump sum of money. And whatever happens to that lump sum of money is what happens to that lump sum of money. So if somebody has a lung cancer surgery and we do the testing inside of that window for Medicare, then there's no more money that comes than what's already in that lump sum. We can't bill Medicare separately. So that's really where the push to wait comes, is that people go, oh, well, I already negotiated for this lump sum, and it includes the surgery and monitoring somebody for a couple days and all the nursing care, and it didn't include the money for that. So we don't want to dip into that pool of money, is really what that's about. It's not that you're not allowed. It becomes a fight about who's going to pay for it. Questions? Yes, sir. The time needed for different types of testing? Sure. Let's see here. I'm going to find some of my slides that I threw in here. Okay, so this is an example of sequencing. And this is the type of test that sort of leverages our oldest fashioned technology using sorts of things that we used to use radioactivity and big gels for, and that we have much more advanced technology for now. Now, I can't speak for every lab. I can only speak for the spectrum of practice I know about. But when you get a sample in, actually I've got a better slide for this. When you get a sample in, there's a few things you have to do with it first. You can see I anticipated lots of things here. Okay, so this is sort of a process workflow for molecular pathology. So sample arrives in molecular pathology and gets accessioned. The first thing that has to happen is somebody has to look at it. That requires a pathologist. So the first thing is a pathologist looks at it to decide, is there enough tissue here? Is it suitable? Is it the right tumor type? Does the testing that was ordered make sense? And then we have to go through what we call specimen pre-analytics. And apologies, it looks like my slide didn't transfer that well, but we do microdissection and DNA extraction. So that process by itself can take 1 to 2 days. And in my lab, from the time that the sample comes in until the DNA is extracted and ready to go, ranges from half a day to 3 days, right? Because some samples just are very difficult and they take a lot of effort. So I can't give you a defined, half a day to 3 days generally is how long it takes. No, not half a day, 1 day. The shortest I can go is 1 day to having DNA extracted. So 1 to 3 days just to have the material ready. And then the testing, we can either do targeted testing or something like next generation sequencing. So if I were to do Sanger sequencing, I could get that result in 2 more days after that. If I were to do that allele-specific real-time PCR, I could get that answer in 4 hours. Now, why would it take a week to get your results back then? Well, when I run an allele-specific PCR, I have to run a positive control and a negative control and a no template control. So I've just burned 3 samples to run 1. So the economics of labs are that you don't like to run batches with only 1 sample in it, right? The economics of labs are that I need to wait until I have 3, maybe 4 samples before I fire off that run. Because otherwise, I just spent 4 tests worth to get 1 answer. I guarantee you, even with the insurance company that pays me the most money for that test, I just lost a lot of money on that test. Guarantee you. Okay? So labs like to wait to batch things. Now, in my lab and in lots of labs, what we do is we have either a batch or a hold until. And that means that I will run a sample with only 1 if it's been sitting there for 3 days. Right? But if it just came in yesterday and I only have 1, I'm kind of obligated to wait a couple more days to see if anything else comes in. So for the targeted testing, the fastest I can get it turned around is usually about 3 days, and that's if I just do everything back to back to back to back. And we've done that before. When we've got somebody in the hospital, they're inpatient, and if we don't get an answer in the next few days, we're just going to start chemo. We do it. We'll stop the horses, we'll grind everything to a halt, and we'll do what we need to do, right? But in terms of routine lab running, that's not what we do on a day-to-day basis. Next generation sequencing is a little more complicated. In my lab, we get our next generation sequencing results out in usually 2 calendar weeks, sometimes less. Some of the commercial entities are running a little bit longer, but they run much bigger panels than I run. So I can't speak to the general thing, but next generation sequencing takes a lot longer.
Time for just one more question.
That is an excellent question, which I will repeat, which is if somebody has a tissue-based answer, the tissue-based result, and they get a liquid biopsy result and they're discordant, whose responsibility is it to, number one, try to resolve the discrepancy, right? Because the first thing to do is resolve the discrepancy. And then the second is to notify all the parties that are involved. So resolving the discrepancy can mean a number of things, right? It can mean doing some additional testing to see if there's other methods that can be used to confirm a result. And that's normally what I would recommend doing. Now, let's say, for example, somebody has an ALK positive biopsy and their liquid biopsy is negative, but I know they went on crizotinib and responded. I don't have a lot of reason to doubt that ALK positive result. So we also put that in the clinical context. In terms of whose responsibility it is to contact them, I don't know that it's dictated that it's any one individual person's responsibility. It might be the oncologist that calls the company that did the liquid biopsy and say, oh, you might want to go look at the data again, right? It might be the molecular pathologist like me. If I get pulled into a case, I would certainly call them, right? I will tell you, though, that, I have no bias in terms of companies. There is no company that is incentivized to publish its data about its misses, right? So while they are interested to know this information to help improve their tests, and I firmly believe that the vast majority of laboratories out there are good players that are working for the benefit of patients. So it's helpful for a lab to get that information back so they can work to improve their processes and improve their tests. It's not in their benefit to include that in their publicized studies, now is it?
Thank you.